Hello, everyone. Maybe we wait for a minute and then we start the webinar. So, myself, Vijay Shriyalappa. I work as a senior consultant at KNCV based out of Netherlands. Good afternoon, good evening, and welcome the panelists, the dear friends and colleagues. On behalf of KNCV TV Plus, I welcome you to today's webinar on operationalizing social protection for TB care and management. Tuberculosis remains one of the world's leading infectious killers, affecting 10.8 million people and causing 1.25 million deaths each year. Yet, TB is much more than an infectious disease. It is a disease of poverty and social vulnerability. While poverty increases the risk of developing TB, TB in turn pushes individuals and families deeper into financial hardships. Recognizing this, the WHO and the International Labour Organization jointly launched the Guidance on Social Protection for People Affected by TB in 2024. The guidance marks an important shift from recognizing social protection as a desirable intervention to positioning it as an essential component of person-centered TB care. It also supports the global commitment made at 2023 UN high-level meeting on TB to ensure that every person affected by TB has access to comprehensive package of health and social benefits by 2027. So the question before us is therefore not whether social protection is needed for people affected by TB, but how we make it work. Most countries already have various social welfare programs in place. Our challenge is to connect people affected by TB with those existing entitlements, strengthen collaboration between health and social protection systems, and generate implementation evidence that can inform policy and scale up. Today's webinar brings together implementation experiences from Nepal, Indonesia, India, and Vietnam, demonstrating the practical approaches to translating policy into action. These lessons are highly relevant for us working to build more equitable and people-centered TB programs. At KNCV, we see this webinar as a start of an ongoing conversation. We are committed to continuing this agenda by fostering knowledge exchange, documenting implementation experiences, and supporting countries to translate the WHO guidance into practice. Thank you for joining us today. To begin this webinar, I would like to introduce our moderator for today, Delia Bocha. She is a quantitative social epidemiologist with more than 15 years of experience in the evaluation of social protection programs for TB-affected people. Over the years, Delia has served as a researcher at London School of Hygiene and Tropical Medicine and has worked as consultant for WHO and World Food Programme. Now I hand over the floor to Delia. I look forward for an engaging discussion. Thank you. Over to you, Delia.
Thanks so much, Shri, and welcome on my behalf to all the panelists and participants. And thank you to KNCV for organizing this very interesting session. So I'll go straight into the webinar itself. We are fortunate today to have a tremendous panel of implementation experts, academics with an excellent background, and people that have definitely spent significant amount of time to translate evidence into action. And I'm confident that by the end of their presentations, we will have way more insight on how this translation is possible. So let me go straight now to the presentation. We will start with Nepal. And I am delighted to welcome Dr. Kritika Dixit and Dr. Anchal Thapa from the Viet Nepal Medical Trust, who are respectively a research manager and health economist in this organization. And they are passionate about the design, implementation, and evaluation of people-centered TB models. Dr. Kritika, I think the floor is yours.
So first, thank you KNCV for giving us this opportunity to share our work. Today, Angel and I will be presenting about our work that we did on social protection, and we are stressing on why addressing the social and economic consequences of TB is so important if we really want to end the TB in Nepal and of course globally. Next slide, please. So to give you a context of Nepal, where we implemented this study, so Nepal is a country in South Asia, and it borders with two big countries, India and China, and which again have a huge prevalence of TB, as we all know. In Nepal, the TB case is high. There is huge prevalence of TB, and Nepal is one of the 30 high TB burden for DRTB. Also, the case diagnosis is low, as almost 40% of the TB cases are yet to be diagnosed or enrolled within the national TB program. And the population also is quite lives in a quite vulnerable position, as 15% of the population live under the poverty line, and of them only 43% of the people are covered with some forms of social protection. And there was one national survey, the patient cost survey, which BNMT also participated in and led the analysis. It showed that 51% of the people with TB, they face a catastrophic cost. So the situation is very vulnerable. Next. So TB is often recognized as an infectious disease, but as we know, there are many patients who face stigma, they face discrimination and anxiety and social isolation. And this has been already recognized by Rodolphe Virchow in centuries ago, but the studies we did in Nepal also says it holds true. Next. And we also found that TB is also clustered. TB stigma and depression is also clustered among people with tuberculosis. And at the same time, we also found that the depression in TB persists throughout the TB treatment, and hence it shows the importance of addressing the social and economic consequences of TB in Nepal. Next. But beyond coughing and medication, as we know that the adherence to the outcome of the TB treatment is determined by these social and economic consequences, and this is again very well recognized by the WHO and TB strategy, as well as the UN high-level meetings in 2018 and 2023. So, in aligning with this, we convened our workshop to design optimal social, psychosocial, and economic support package for people with tuberculosis, where we invited people from National TB Program and national NGOs who are working on tuberculosis, as well as some of the organizations who work for the livelihood program and social protections. So what we found, what we had, the output of this workshop was that the stakeholders recommended and voted to have some sort of social support for people with TB, and that included mainly for the reduction of stigma, as well as the stakeholders also recommended to have unconditional cash transfers, so that they can curb the burden of economic financial burden of TB. Next slide. I can see the comment that people cannot see the slide, but can you confirm? You see the slides?
I can see it. So
okay, thank you so much.
I can too.
Okay, yes. Thank you. Okay, so just to so we really wanted to address these challenges, and therefore in order to scale up or recommend this for the national TB program, there raises an important question: that are these recommended social and economic packages could be integrated into the national TB program, so that it is acceptable and feasible for the scale up beyond the project. So this work, and there this is where the ASCOT project was piloted, and this was led by Dr. Tom Wingfield, who was the principal investigator of this project, and it was implemented by Bhola Rai, the project manager, BNMT, and he's also here attending the webinar. So if you have any questions, you can also ask him for the clarification. And we have already completed this study, and this is under publication at the Lancet Regional Health South Asia. Next. So I would like to give you a brief about the methods, what we did. So this study is about 4 arms, unblinded, individually randomized control pilot trial. And the participants were adults with drug-sensitive pulmonary TB. So the 4 arms included the control group, where we provided one-time food basket. The social support included household visits, and we also had TV clubs where people attended 2 sessions, and a locally appropriate video was developed in order to reduce the self-stigma. We also provided economic support, and another group received socio-economic support. So there were altogether 128 participants who were equally divided into 4 arms. And the study was commenced in 4 districts in Nepal. And as you can see in the map on your right above, the blue color highlights where we implemented the study. Next. So the primary objective of the study was to measure the feasibility and acceptability, as I mentioned earlier, whether the interventions are feasible to implement and whether they are acceptable by the people. So basically, the feasibility, we measure the fidelity to recruitment, follow-up, and the interventions, and we also checked with the fidelity to the protocols. Acceptability was measured with the participant survey and the feedback and the response and the discussions within the key informant interviews, focus group discussions, and in-depth interviews held with national TB providers and the people with TB. Next. We also had a secondary outcome where we measured the cost using the WHO patient cost survey, which was validated by us in our previous studies, and we measured the cost at 3 different points of time, which my colleague Achal will be talking about shortly. Next slide. So now let me go into the results. So what we found. So as we measured the fidelity to the intervention, we found that across all the interventions, the planned activities were successfully completed. The cash transfers had high completion rate in both economic and the socioeconomic arm that ranged from 94 to 100%. Next. We also had home visits and counseling, which also had a very high completion rate of 84 to 94%. And as you can see in the quotes here, the people also had a very good reaction to the cash transfers, as they were timely supported, and the cash transfers were helped them to reduce the out-of-pocket cost, for example, to buy their fruits or any of the food, nutritious food that their healthcare providers would ask them to eat. Also, the home visits were very appreciated, as people mentioned that they were good counseling and they could also ask any side effects of the medications. Next. So the TV clubs was one of the another interventions that we had, which also had a very high completion rate, but little so in the social arm. And that was mainly like we found few participants who had other priorities. Also, some of them, they could not afford the cost to attend the TV clubs because there was less of the transportation cost we did not provide. So that's why we found a less attendance, but again, it was rated to be very high, as good or very good. Next slide, please. I just want to reiterate that acceptability was very high in the study, and together with these findings, it demonstrates that a comprehensive social protection package is both feasible to implement and highly acceptable to people with TB. And now I would like to ask Achal to continue. Thank you.
Thank you. Can we go back, Yuan? One slide back. Yes, thank you. I just have 2 more slides, so please bear with me. So since this was a pilot trial, we had compared the proportion of people with TB in each study arm by the rates of the incidence of catastrophic cost as an unpowered exploratory secondary outcome. So the findings here I'm presenting is the findings from the WHO patient cost survey that we conducted. And as you can see, the catastrophic cost, about overall 32% of the participant households had incurred catastrophic cost. And the economic support that we provided to the 2 arms, which is basically the unconditional cash transfer of around $24 per month, and which equates to around $144 for 6 months treatment. So by accounting for the cash transfer amount, catastrophic costs were incurred by 25% of the participants in the psycho-socio-economic arm and the economic arms, as opposed to the psychosocial and control arms. Catastrophic costs were incurred by only 39%, as you can see on the right-hand side of this slide. Next, please. So finally, the operational lessons from implementing this pilot trial. The findings of this pilot trial adds to the evidence that integrated psycho-socio-economic support for TB-affected household is feasible and acceptable in high-burden LMIC setting like ours. Plus, it is programmatically viable in a setting like Nepal, as it does not require specialized clinical staff and can be delivered through existing national TB program structures and NGO partnerships, hence supporting the overall NTB goal. The psycho-socioeconomic intervention is suitable for national scale-up. However, need-based targeted mechanisms should be ensured to identify and only serve those people who need it the most. Also, with as expected, financing and workforce planning must be addressed early, as sustainability depends on the ring-fence budget that is available. And the cash transfer, finally, the cash transfers appear to facilitate the participation in socioeconomic social support activities. However, cash transfer amount need to be benchmarked and potentially standardized. So the $24 per month rate we had used was matched to the Nepal's existing DRTB cash transfer scheme, which was seen as fair and feasible to administer, offering a ready-made policy anchor for extending support to drug-sensitive TB, which currently receives none nationally. So with that, I have my final slide, an acknowledgement to all of the people who had contributed to this study. Thank you so much, and thank you for inviting us.
Yeah, and thank you, Kritika and Anshul. Now I will go straight to our second presentation that will take us to Indonesia. It is my pleasure to introduce Dr. Hamad Fuhadi, who leads the Health Economics and Policy Research Group at the University of Indonesia. Dr. Fuhadi, the floor is yours.
Okay, thank you, Delia, and thank you everyone for joining us in this session. So I will present the psychosocial support that is implemented in our pilot study in Indonesia. We call it TB CAPS, so community-based peer-led psychosocial support to address TB stigma and depression. We work with Liverpool School of Tropical Medicine with Tommy as our principal investigator, and our Indonesian team in Jakarta and Padang. So why psychosocial support matters in Indonesian situation? So we already know, as Kritika already explained, about the tuberculosis as a social disease. So in our previous study, we found that there were 61% of our participants had a moderate to severe TB stigma in 7 provinces of Indonesia. They had also depression symptoms that is quite high. It's about 1/3 of people with tuberculosis had the depression symptoms. And also in our previous study, we also found that the catastrophic costs that also contribute to the mental health issues in amongst the people with tuberculosis. In drug-sensitive tuberculosis, about 36% of them experience catastrophic costs, and much higher among the drug-resistant tuberculosis. So we think that psychosocial intervention, which is developed in the community-based and provided by the peers, would be the intervention that can contribute to reduce the TB stigma and mental health. So what we did first is we did a scoping review to check whether there are previous interventions that already developed either in tuberculosis or other infectious disease. And after we did a scoping review and then we listed all the potential interventions, we did a Delphi survey and a national participatory workshop to formulate what kind of social support, what kind of psychosocial support that are appropriate for Indonesian context. And then we shortlisted interventions and proposed the final intervention after the national participatory workshop. And then we finalized the interventions, module development. We developed the module and we did the module training for the peer to provide the psychosocial support. We did the intervention, and then at the end of the study, we did the evaluation to assess the applicability, scalability, and sustainability of the intervention. Okay, and all of this process, we work with the civil society organization, the TB survivors, healthcare volunteers, district health offices, primary healthcare centers, and also the academics in 2 cities of Depok and Padang. And the first, in the scoping review, we found several potential interventions that we want to shortlist and develop. And then in the national participatory workshop, we finalized the package. We call it the package. Consisted of 4 programs. The first one is individual counseling at the beginning of the tuberculosis treatment. And the second one is monthly group counseling with a peer-led and medical doctor supported the counseling, and community-based TB stigma education and personal contact groups. And this was a non-randomized single-arm interventional study in 2 cities of Indonesia. We decided to go to Depok and Padang in the previous study of TB stigma in Indonesia. Padang is quite high proportion of moderate and severe stigma. And in Depok, even though there was no previous evidence about the TB stigma and depression among people with tuberculosis, but we decided to go to Depok because it's quite similar with Jakarta, with the highest TB stigma and depression. We went to primary healthcare centers for drug-sensitive tuberculosis and the 2 hospitals, one in Depok and one in Padang for drug-resistant tuberculosis. And this is what we did. The first one, we among the 136 individuals which were newly diagnosed with tuberculosis, we did a baseline assessment with 129 participants. And then after the baseline assessment, we assessed the depression, the stigma, and the quality of life. And then we did the individual counseling with them. And after that, we invited them into the monthly group counseling and personal contact and group communications. But only 112 out of 129 participated, but it's very high participation rates. It's 97 participation rate. And then at the during the monthly group counseling, we also held TB talk in the community. And then we assess in the month 2 at the end of the initial phase and the assessment at month 6. So the completion rate of the month counseling is very high. It's about 97%. And at the end of the study, we did an evaluation. We did the FGDs, focus group discussion and interviews with some of the participants, with the relevant stakeholders, and we did a survey among them, among the participants, about the acceptability, feasibility, and applicability. And at the end of the study, we did a national participatory workshop to conclude what we found in the study and ask all the relevant stakeholders what they think about the replicability of this kind of intervention. So we found here in Depok, moderate TB stigma is very high, 85% in Depok and 41% in Padang. with at least moderate TB stigma, and overall it's about almost 70% of participants had at least moderate TB stigma, so moderate and severe TB stigma. And it is mostly about the disclosure, afraid to tell others and choose carefully to whom to tell about TB. And there are some differences between Padang and Depok. In Padang, the isolation issue felt hurt, how others react to knowing that they had TB is more prominent. But in Depok, is more prominent about guilty feeling, so becoming a burden of family to take care. And after the intervention, we see the assessment in month 2 and month 6. We can see the decrease of TB stigma score. There was significantly decrease also in the depression score using the PHQ-9, and increase significantly in quality of life. And we can see here in decreasing TB stigma, we can see the effect in the month 2. Month 2 and month and increasing quality life or quality of life also we can see in the second month of the intervention. So we also interpret our findings like even though that we did the study for 6 months, but we have already found the differences or the impact, the effect of the decrease of TB stigma and in the quality of life and the depression at the second month. So maybe if the government cannot afford to fund for the whole 6 months for drug-sensitive tuberculosis, we are quite confident to say that doing this intervention, when it is done properly, the effect can be seen in the second month or the initial phase, is in the disclosure domain, isolation domain, and the guilty filthy domain. And at the end of the study, we assess the acceptability, appropriateness, and feasibility for overall TB CAPS activity, and almost all the participants and also the workshop participants say that the acceptability rate and appropriateness and feasibility rate they perceive as high agreement. And also for the group counseling, which is the main part of the intervention, the acceptability rate is very high. Okay, I think that's all from Indonesian lesson learned from Indonesia. This is our team during the national participatory workshop. We also invited some philanthropic organization at the end of the workshop to see whether they are interested in to fund the intervention if the government cannot fund it because of limited funding. Okay, thank you very much. Back over to you, Delia. Thank you.
Thank you so much, Dr. Hamad, for staying in time. And now we move to Vietnam, where we will hear from Dr. Rachel Force, who is an implementation specialist with more than 15 years of experience in Vietnam, where she worked as senior manager in the Friends for International TB Relief. Dr. Force is now working as consultant for the Stop TB Partnership, and she also holds a research appointment for the Karolinska Institute in Sweden. Rachel, the floor is yours.
Hi, everyone. It's nice for you to have organized this and to have invited us. So I'm going to be talking about kind of a body of research that happened in Vietnam over the last 8 years, and then present some preliminary results from a trial that we were able to do just last year. And so this is the first time I'm presenting these results, and I'm quite excited to share this information on behalf of the team in Vietnam. So I'm not going to give a broad summary about social protection, but just give you a little bit of information about TB in Vietnam. And that is, it's the 12th highest burden country. About 184,000 people per year will develop or are estimated to develop TB. We know from national costing surveys that 63% of TB-affected households are going to face catastrophic costs. In our context, this is primarily driven by income loss and not direct medical expenditure. So after the first national patient cost survey in Vietnam, the National TB Program actually established a fund to mobilize domestic resources and then to identify the people with the highest levels of vulnerability and provide support to them. In India, they have this in the direct benefit transfer. In Vietnam, we don't have universal access to this fund, which is called Pass TB. It's really targeted towards people who are hospitalized with more severe presentations of TB or having living below the poverty line. And then also something you should know about our social protection system is that the country has really worked over the last 25 years to have national social health insurance coverage. And so 95% of the general population has social health insurance. And in 2022, all the first-line consultations, the diagnostics, and medicines are covered by a health insurance reimbursement. So this does put some amounts of co-insurance payments onto people because they pay 20%, but the government would then subsidize 80%. And so this is not totally free of cost care, but it is a, domestically financed TB program that is providing support. So a lot of the other presenters have talked about TB-specific social protection. There are programs designed for people who have TB. But in Vietnam, we're also really trying to focus on how we can make the social assistance sector, the national social health insurance, also TB sensitive, so that people with TB can benefit from these broader social protection programs. The work that we did in Vietnam has really spanned, as I said, about 8 years. And we spent 6 years kind of doing formative research. So we did a study on acceptability. We did a study on what are the preferences do people have, and what types of support would they like to have. We did a pilot where we looked at how do we enroll people, all the people who come and are on TB treatment, but they don't have insurance. How do we help them get on insurance? And we were able to see that about 76% of people are able to be enrolled. About 24% are unable to be enrolled, and they may be permanently uninsurable under the current conditions. So it takes about 34 days for somebody to get onto health insurance after they were enrolled in the pilot, and it costs about $66 US. So we also did another pilot where we looked at providing conditional and unconditional cash transfers. So we started asking, should we ask people to meet certain criteria in order to receive cash transfers, or should they be provided regardless of participation in treatment? And what we found in the Vietnamese context is that people did have a preference for some conditionality, that they wanted soft conditions where people could make up for missed conditions, but they wanted to see active participation in treatment as part of the criteria for receiving some support. Okay. We also did a people-centered design process where we tried to identify all sorts of problems across the cascade of TB care. We did a range of stakeholder interviews with 88 people throughout the whole country of Vietnam to identify what are the biggest priority challenges that are being faced. And then we created a leadership group where we validated these challenges and then selected the priority areas. And in the end, this group, which was kind of completely separate from that earlier formative work that I was talking about, but it was a national initiative in preparation for and to complement the national strategic plan of Vietnam. We then identified some challenges and prioritized programs, and then we gave the people in the leadership group the control in order to select what a future intervention could look like. And at the end, 81% of the final vote tally said that we should work on social financial protection as the biggest problem within the Vietnam's TB program that should be addressed. So after all of that work and the co-design process and the co-prioritization and selection of this grant, we then used our funding to work on a study named Uplift. And it's a type 2 hybrid effectiveness implementation trial. So that means you're studying both the implementation of the trial and the fidelity to the protocol, these kinds of things, but also the effectiveness of the intervention. And so this was a larger trial. We had 1,334 people randomized across the 12 districts, and you can see the districts and the provinces here. So I made this slide to kind of show you the research questions that we're asking, because it gets a little bit complicated, but we had the 1,334 people who get individually one-to-one randomized into an intervention and control group. And from them, we're asking, does this intervention improve treatment success? And then we have a subsample of people who are going to receive longitudinal 3-time point costing surveys throughout care. So they're met several weeks after they initiate treatment, after the end of the intensive phase, and then at the end of treatment. And we ask a range of questions here, but the primary one was, does the intervention reduce catastrophic costs? And we have a range of secondary outcomes. Does it improve health-related quality of life, TB stigma, depressive symptoms, and then household health seeking, including health insurance enrollment? So then who was included in this study? It's adults who are over 18. This was for drug-sensitive, drug-susceptible pulmonary TB. They needed to be notified in the National TB Program's digital registration system named Viet Nam, and then they needed to be the first member of their household to enroll. So the intervention included 2 components. This is kind of similar, I think, to what's being done in Nepal and Vietnam, but maybe slightly different. So we had peer-led TB clubs. So we identified people who had former TB patients who then were provided with training, and they would coordinate with the district TB unit staff to conduct a peer support group every 2 weeks at the district TB unit. And we had a 10-session curriculum, and it was quite structured, and we have all of the materials if anybody's interested in them, where you can take and each week present something that's slightly different. We also had a Q&A session with the providers who are coordinating care at the center. And then if people attended the clubs, they were provided with cash transfers. So we gave, it was 1 million Vietnamese dong. This is a little bit more than $40, and they could receive up to 3. And you received, for the first time you joined a club, a second time, and then a 6th time. And this came out from the formative research. This pattern was from the formative research, saying that we know that the greatest cost burden is during the intensive phase. So we need to kind of front load the cash that's available then, but then we wanted to also reward continued participation. So these are the first results. I want to provide a disclaimer that we're still finalizing this, but we're seeing a 3% absolute difference in proportions in treatment success when you compare the intervention and control. If you look at the intention to treat, that means everybody who is kind of randomized to intervention and control, we're seeing an adjusted odds ratio of 1.51, which means that you have 51% greater odds of treatment success if you were in the intervention group. And then we're looking at a modified per protocol definition, which is saying, okay, going back to this slide, anyone who had a negative outcome before having 1 month of eligibility to participate in the club. So really not dropping out too soon, but being able to participate, they then had greater odds of success, treatment success.
1 minute left, Rachel.
Okay, I'll go very quickly. We're also seeing some interesting things with catastrophic costs. So not statistically significant differences between the arms, but we are seeing that direct costs are lower by 40% and significant increases in health insurance renewal for the participant in their household if they were in the intervention group. I'm going to skip this one, but we worked with the National TB Program to kind of build a digital health system, so we were able to provide support from that national fund I was discussing before through their digital platform, and try to really expand usage of support and make sure that Vietnam has the systems to deliver it. In terms of operational issues, I would say for somebody in an organization starting, just begin where you're at and start building evidence over time. Don't wait for the perfect trial funding in order to start providing this kind of support. Engage people in intervention design. Many of these studies have really combined psychosocial support with financial support, and I think that that's a really effective strategy because people need both. If your country has existing social protection, I would say to use it as much as possible and help them navigate those wider social services. And then delivery of support is just as important as like the access. And then lastly, you really need to go and iterate. So I'll stop there. I know I'm a little bit over time, but I just want to thank you all and thank our donors who are listed here, and then all of the participants and the team who's worked on this as well. So thanks so much.
Thank you so much, Rachel. Great results. So we now move to our last presentation from India with Dr. Prachi Shukla, and again, another implementation specialist working for World Health Partners. Dr. Shukla has dedicated her life to the translation of evidence into pragmatic and concrete public health interventions. Dr. Prachi, the floor is yours.
Hi, everyone. I'm Prachi Shukla. I'm from an organization from India called World Health Partners. And before I begin, I just wanted to acknowledge the broader collaboration that supported this work. This project was implemented over a 12-month period in Delhi in collaboration with Dr. Vijayashree before she even joined KNCV and all the local health stakeholders. I will not spend more time on this because already the previous speakers have already spoken on it, but I just wanted to tell that India has the world's largest TB burden, and around 45 to 58% of registered TB fall in the category of below the poverty line. So we exactly know the link between the TB poverty trap, and it mostly actually hits people who are below, who have that socioeconomic vulnerability. So this slide, basically it tells about, highlights the major gap between the awareness and actual access to welfare support. And while you can see that in the project area, almost 98%, which is absolute majority of patients, they've actually heard that there were some government schemes already there, but only 1 to 3% could actually identify a specific scheme or explain how to access it. And as a result, we know that it was very clear that the passive information sharing alone wasn't sufficient, and the patients required actually structured facilitation and active guidance to successfully navigate the linkage process. And in this slide, it's the project scope and the demographics. And the study was implemented over a 1-year period, as I said, from January to December 25, in one of the urban slums in the capital of India, Delhi, which has very high socioeconomic vulnerability. This intervention focused on TB patients, which were from the economically vulnerable communities. And the other good part of the study was that we did not reinvent the wheel. We worked with the people who were already a part of the TB program. So that made the project easier to implement, easier to scale and understand. So we implemented the study in 3 phases using both the quantitative and qualitative methods. Our objective was not just to help TB patients access the welfare schemes, but also to understand what actually helps or prevents them from getting linked to these benefits. So in the first phase, as you see, we carried out a baseline assessment identified existing 11 welfare schemes which were relevant to TB patients through policy reviews, and then spoke directly to the people who were involved. We surveyed 300 TB patients, assessed the knowledge of the frontline workers, conducted focus group discussions, etc. And the second phase was implementation. We trained the frontline workers, followed up with patients, and worked very closely with the health officials and community leaders. Finally, we evaluated the intervention to see what actually worked. We assessed how many patients were successfully linked to welfare schemes, and equally important, try to understand the operational factors that influence the success or failures. Here in the slide, as you can see that once the intervention structure was in place and the frontline workers were trained, we developed a very simple step-by-step workflow process to help these eligible TB patients access the welfare schemes. So it started with training of these workers on available schemes, eligibility criteria. So we identified all the training contents, etc. And once these were trained, we help the patients also understand the benefits that are available to them. And our frontline workers also provided practical support for documentation, whatever bank documents were required or their identity documents were required. And but we also train them that do not stop after submitting the application. So these people regularly followed up with the patients through phone calls, WhatsApp, and online portal to resolve delays and ensure that the applications that were submitted was moving forward. For us, this process was complete only when the patient had actually received the welfare benefit or the direct benefit transfer. Now, after that, what we did was that we actually successfully linked 175 TB patients and their families to different welfare schemes. And in this slide, you can see there are acronyms here, which are very specific schemes by Government of India. And most of these linkages were under the financial inclusion and health protection schemes like the Pradhan Mantri Jan Dhan Yojana. And there were various specific schemes that they were linked to. We also helped eligible beneficiaries access the widow pension and disability benefits. So these are the schemes which are not directly related to tuberculosis, but they are actually related to people on which affects their overall quality of life. Someone in the family is widow. We were able to link these people with those specific schemes. And one of the encouraging findings was that whenever patients met the eligibility criteria and the administrative system was functioning well, the linkage process worked very effectively. At the same time, we also came across some very important systemic challenges. For example, although many people were eligible for old age pensions and were aware of the scheme, they could not get enrolled because district level quotas had already been exhausted. This showed us that while community-based interventions can successfully overcome awareness and access barriers, some challenges can only be addressed through policy and administrative reforms. While this project did not just benefit the patients, TB patients and their families, but it also benefited the health system, because we were also continuously working towards strengthening this health system by building the capacity of the frontline workers there and all the other people who were actually responsible for day-to-day care and the administrative stuff for these TB patients. Before the training, we saw that their average knowledge of these frontline workers was almost around 66%, but after structured training and mentoring, it increased to nearly 97%. So more importantly, they gained the confidence and skill to identify eligible patients, guide them through the application process, and support them until they received their benefits. So as we implemented the intervention, a few challenges became very clear. First of all, that many patients lacked the required documents, which made our lives and their lives absolutely difficult because we needed to complete their applications. So frontline workers also needed ongoing motivation because, as you know, these frontline workers, they are also involved in various other works apart from this. So ongoing motivation was something which was very needed, and as the welfare linkage was seen as an additional responsibility. We also face delays due to fragmented digital systems and slow processing by the banks and the government departments. The biggest takeaway was that the frontline efforts alone are not enough. Stronger coordination across the health system and welfare departments is absolutely essential to ensure that patients receive benefits on time. Um, this is actually the blueprint for institutionalization, what it takes for the system to take this up. So our experience showed that linking the TB patients to welfare schemes is actually both feasible and impactful. But for this to be sustained, it needs to become a part of the routine health system rather than remain a pilot project. This means formally integrating welfare linkage into the TB program, regularly training frontline workers, simplifying digital and referral systems, and improving coordination across the departments. At the policy level, dedicated welfare provisions or reserved quotas for TB affected families could also help ensure that eligible patients receive timely care. So we learned that until and unless this is integrated and becomes a part of the routine services, it won't be sustainable. This is the last slide, and we all strongly feel that ending TB actually requires treating the socioeconomic symptoms as aggressively as the biological ones. So the TB does not end with medicines. It ends when no family is pushed deeper into poverty because of his disease. Thank you.
I've been monitoring the Q&A, the chat box, and I could only see, in fact, one question from Dr. Nasrat from Afghanistan. So I encourage people in the audience to put forward their questions, if any, or raise their hands if they prefer to speak rather than writing their questions in the chat. In the meantime, I'd like to take advantage of the questions put forward by a colleague from Afghanistan to ask, starting from Dr. Hamad, about the sustainability of this intervention. With your work, you have assessed a number of criteria, the acceptability and others, but I wonder what is your perspective about the sustainability of your interventions or the interventions that have been presented today, and how they can be converted into programmatic action for TB rather than single research interventions or program. And then as soon as you answer, I will have another follow-up questions for all the other speakers.
Okay, thank you so much, Delia and Akmal, for raising this issue. As I say that at the end of the National Participatory Workshop, we delivered the findings to them. And then we also informed them the cost of the interventions is about 26 to 28 US dollar per person with TB. And we asked, after we inform the intervention effect and then the costs from this intervention, and then we ask them whether it is reasonable budget or not. And then reflecting on this cost during the workshop, participants, including the National Tuberculosis Program, actually perceived the cost as reasonable, and it is possible to budget for in NTP activities and to integrate into routine practice. But the difficulties is we have to compete with other interventions, right? With the cut fundings. Recently, we have a shortage of fundings, and then we need to advocate more and more. So the thing are, we want to integrate it not only tuberculosis issue here, but psychosocial support for tuberculosis should be also integrated into the mental health services. So we are now thinking how to integrate it. So it is not a single intervention for TB, but also for mental health and the for health system itself. So for the sustainability, it is still a process how to fund it and include it in the budget, the national tuberculosis budget, and also in the global fund budget, which are recently we proposed to global fund. Thank you.
Thank you very much. Is there any other question from the audience? Anyone who wants to add anything to what has been discussed so far? If not, I have a follow-up.
I think there was one question for me, and because we are talking about sustainability, I can also chip in.
Yes, please go ahead.
Okay, sure. Thanks, Delia. So I think there was a question regarding the sustainability when the coverage of social protection in Nepal is around 43%, like less than 50%. So I would like to say that, I mean, we all know that the social protection interventions have demonstrated good outcomes for people with TB as well as for other diseases. But like for Nepal, it is the social protection is still in infancy, I would say, and that the government is trying to design and develop appropriate social protection interventions. And having said that, it is still under priority, and that is why they are reconsidering the design. Most of the social protection, they are in silos, so there are different schemes for different people, and they have prioritized elderly population the most. And also in Nepal, the TB population, they belong to the elderly groups, like 55 years and above. So in some ways they are being protected already. But also I would say for the sustainability, the government needs to prioritize the internal budget and not depend on the external fundings. And as we know, there are so much other negative consequences because of this. And also what our studies have shown is that, and this is very in line with the current government assessment regarding the social protection, is that the blanket approach is really difficult for the government to handle. That is why our study also shows that there is a need for targeted approach, like the people who are from a very poor, ultra poor socioeconomic condition, then they should be prioritized. And because there are so many risk factors that also resembles with the TB, and I believe that this kind of support system, the targeted approach, would be essential. To address the needs of people with TB. Yeah, thank you.
Thank you, Kritika. So we are a bit over time, but maybe we can devote a few more minutes if Sri, you agree to see if there is any more questions from the others, or at least yeah, okay. So there is one question from Dr. Anthony from Nigeria. How do you resolve issues around fragmentation and coordination on social services and TB program are offered by different government agencies? So maybe, Rachel, would you like to address this question? How do you see the fact that the social protection sector operates in different type of programs, and how you can better coordinate with the National TB Control Program? Have you thought about that?
Yeah, I think this is a challenge in almost every country, that, we've set these different programs up in silos, and now we have to kind of try to bridge them. I think that the way we really did this is we had used community healthcare workers to try to bridge between, especially when we were enrolling people in health insurance, and making sure that they could access support. Over time, we saw that over the last 8 years, it really has become a bit easier to do that. And there are more places where you can get registered in social health insurance, these kinds of things. So that's one specific way we did it. But I think also kind of designing together, going and saying, let's do co-design and get the different organizations in the room and building a program, knowing that there's going to be fragmentation and coordination, and letting everyone have a seat at the table choosing interventions that involve social assistance, and then the social assistance sector, and then making sure that they're there from the beginning, not brought in with a to-do list without potentially even additional funding and these kinds of things. So I think making sure that you're really co-designing and treating everyone as equal partners at that phase really does help with the downstream fragmentation that does eventually happen.
Thank you, Rachel. I think that we will probably close here unless there is any other pressing comments or question from the audience. I think it was a very exciting set of presentations that have provided us with very good examples, strong examples of how you can pragmatically try to ensure that people with TB receive effective, sustainable, and equitable social protection benefits. I think that the key question is how you translate now this evidence into programmatic action at the National TB Control Program, and what would be the first step for the National TB Control Program to absorb this evidence and to become involved in this kind of activities at the more programmatic evidence. I think this is our work for the next few years at least. I leave it to Shri for any further closing remarks, and I thank you again, all the participants and the panelists for their participation today. It was a pleasure to host you for this webinar, and again, thank you very much to KNCV for organizing this event. Shri.
Thank you, Delia, for this wonderful moderation. We see this webinar as a start of the conversation, and I think as a group, we would really look forward to continuing this agenda forward in terms of knowledge exchange, and let's start documenting this implementation experiences. Thank you, everyone, the speakers, for sharing this wonderful experiences and the audience.